I wanted to pair. I do want to get started and explain the title, and Malaz, as appropriately mentioned, that I'm going to accomplished in deprescribing so far, and what the next 6 months to 9 months looks like in this work. So I wanted to start with our title of the Christmas story, and everybody knows Ralphie, and it's about that time for us all to get sick of this movie by the end of the weekend. But Ralphie and I were somewhat alike in that I was in appearance at least, I was a blonde-haired, blue-eyed little kid, but I grew up. And so this is me now. And so as Malaz mentioned, I've spent the early part of my research career trying to understand from primarily epidemiologic work, the adverse cognitive effects of medications. But I've grown up, I got a bit uglier, and now I'm shifting towards what happens when we take those medications away. Thievery, if you will. So I thought a way to attract people to attend today, at least those who read the title, would be to combine Christmas and my work. So let's talk a little bit more about, as I jump in, I'm going to talk about one of the first definitions of deprescribing. There are a few definitions about publications, not about publications, but about deprescribing in publications. And they offer slightly various forms, but one of the most easily understandable is this from 2013, from Wade Thompson and Barb Farrell up in Ottawa. And it describes deprescribing as the planned and supervised process of dose reduction or stopping of medication that might be causing harm, or at least might no longer be causing or providing benefit. And the important part of this to understand is that the intent of deprescribing can have two purposes. One is to address the problem of polypharmacy that is a significant problem rampant throughout the older adult population, but could also be in younger adults as well. And the second is to understand whether medicines are really consistently providing benefit. And it gets at some of the limits of what we know about medicines and how they work, and particularly how long they work. We have very little data about how long whether medicines continue in their expected efficacy and safety parameters for 3 years, 4 years, 5 years. And you can walk into most clinics, many geriatric clinics, and find somebody who's been using a medicine, for example, fluoxetine, for 20 years. And we don't really have significant routine, high quality data to understand whether there's sufficient support for that practice. So I'm going to prime you a little bit here with some of the things that I might take your feedback with, and Malaz was wise to start early because I tend to run on. So my goal is to allow us sufficient time for questions, for clarification, or even some feedback in these particular directions. So I'm going to tell you a little bit about some of our work in invite your input on best practices for physician-focused computerized alerts, which we're now implementing in Epic. And offer maybe some suggestions on how you've engaged patients and caregivers in printed, mobile applications, or web-based educational materials, which we're now using for deprescribing purposes as well. And then there are some additional considerations that I don't want to unblind you from quite yet. All right, so I'm going to share, the next couple slides I'm going to share with are primarily from what I shared with the External Advisory Board last week, maybe 2 weeks ago now. And I want to start again with my mission as an aging brain researcher and a pharmacist as well. And that's particularly focusing on medicines that keep the brain healthy. And so my research mission is to improve the brain health of older adults through the development and implementation of safe, rational, evidence-based medication management strategies. So again, as we mentioned, about a decade ago, we started a process to identify in the best, most scientific way that we could, which ended up being a fair amount of expert opinion. But again, with the absence of evidence, this is what we're left with. So we developed the Anticholinergic Cognitive Burden Scale in about 2008 and revised it in 2012 and released it through publication in 2013. And I've been using that since 2008 to identify and quantify what the adverse cognitive effects of medications are. And so more recently, through support of K23 from the NIA, we've been able to quantify different types of exposure variables using the scale, whether you just sum the severity of the scale scores, whether you use, or whether from something simple to saying whether someone was using a medicine, yes or no, as a categorical outcome versus using the rich data that Regenstrief has to offer in medication, in the dose of medication, the duration dispensed from the medication dispensing and claims data. And so we've identified that perhaps the best way to quantify medication exposures through that rich data where we find more significant adverse cognitive effect risks. And most recently, the K23 identified or quantified these risks from older adults in primary care who are very early in their cognitive trajectories or cognitive decline. So these are people primarily with either normal cognition or mild cognitive impairment, and we measured the influence of medicine on their risk of transitioning towards worse cognitive impairment or medicines preventing the reversion to better cognitive impairment. And so the box at the lower left that you see here describes some of those the ways that we've calculated anticholinergic burden through different variables, but then we've also been able to look at some other classes of medications and really honing in on what are the potential targets for improving brain health through medication interventions. And so pretty quickly I'd say pretty quickly in this research, when we find a relationship between medicine and adverse cognitive effects, the next question becomes quite relevant, right? So if we find a group of medicines that are worsening cognitive outcomes, the next question is it reversible? Essentially asking the question, if we take people off of the drug, if we deprescribe, do their brains get better? And so that led us to this field of deprescribing, which has really expanded most significantly in the last 5 years, roughly. And we understood as we started to learn about deprescribing, we didn't realize it or brand it as such, but for the past decade, and actually for the past 12 years, we've conducted 3 deprescribing trials. And our deprescribing interventions were somewhat rudimentary, as you might think about now. But the first was Malaz's eChamp trial, which instituted an alert and an alerting system in the Gopher computerized decision support physician order entry system, where we told physicians when they're trying, and on the inpatient side, when they're trying to order an anticholinergic medication, we interrupted them and said, maybe you should think about a different medicine. And I've got in the next slide, the figure here shows what that interruptive alert looks like. And we learned from that, so that particular study was negative. We weren't able to change the prescribing behavior from that deprescribing intervention. So we asked physicians and providers who interacted with that alert, how would you suggest, we told them we aren't successful in changing your behavior, how would you suggest we improve that so that we could have a more significant impact? And we heard from them that they generally don't trust those alerts. They don't believe they apply individually to a patient, although they may apply to a population. And we said, what can we do to make it better? And we heard from them, well, give us a human, give us a pharmacist to support that intervention. And so if we don't pay attention to that, have a pharmacist call us and tell us that we should pay attention to it. So we tried that in the second round of trials, in the PMD trial and the DPMD trial. And the DPMD standing for deprescribing deprescribing specific component of the pharmacologic management of delirium. Again, both inpatient trials, the PMD and DPMD in the ICU, where we had not only the alerts, but we supported the alerts with a human pharmacist who would call when the alerts would fire and no response was provided by the prescribers. And we've got 2 papers that are either accepted or nearly accepted of those trial results. And unfortunately, we again were not able to change prescribing behavior for anticholinergic medications out of a combination of these alerts, as well as a human pharmacist to call. And so we began to circle back around, like, how do we improve deprescribing interventions if we've got physician-focused alerts that aren't changing the practice? And so we've turned, through the influence of Dan Clark and Rich Holden, we've turned to the field of behavioral economics and IT and user-centered design. And we discovered the mind space influences to understand how can we change, if we see prescribing as a human behavior and essentially deprescribing as a human behavior, how can we better design our interventions to adopt these policies or incorporate these influences of human behavior? So you can see in the table on the left the mind space and interventions that we're beginning to adopt and use. Considering the source of the messenger, who's sending the message, who's providing the message to the provider, and or any other influence, any other stakeholder in the prescribing process. So quickly, I'll run through these, and the table on the left tells us what parameters I believe that we were using when we introduced the first round of deprescribing interventions, the first generation of deprescribing interventions. And so we did pay some attention to the messenger, but if you can see, for those who can see the picture or figure on the right, the first part of the alert that popped up said, do not use if child less than 2 years old. Well, if you're a provider and you have very limited time for about anything, and you see an alert that pops up and it starts with something about a child less than 2 years old, you may not read much further because you presume much of that text is related to that child. And you're not prescribing for a child the way these alerts are designed. So you probably are F8ing out of this alert. And that explains some of the design flaws that we had in the first round of deprescribing interventions. So we paid attention, so we introduced, or we educated ourselves on what these second round of design influences how they could help us in designing better deprescribing interventions. And so the first parameter being the messengers, we're heavily influenced by who communicates the message. And so we've tried to pay attention to that. Now, deeper in the text of this original alert, first generation alert, we did pay attention to a messaging component. And somewhere in there it says, a group of local experts has decided that this is an appropriate practice for us at our facility. That's the extent to which we paid attention to messaging. The second behavior characteristics are incentives, and that our responses to incentives are shaped by predictable mental shortcuts, such as strongly avoiding losses. So we're heavily influenced, not necessarily by gain, but behavioral psychology says we're influenced by avoiding loss. And so we paid no attention to incentives. Norms would suggest we're strongly influenced by what others do. So if we know that everybody else is doing it, then we're more likely to do it ourselves. We paid no attention to that. Setting defaults. And so the most common example here is in setting defaults, particularly if you consider your paycheck. So if you set defaults so that you automatically contribute out of your paycheck to your retirement account, then you don't miss that money. You don't have the money to then have to distribute to a particular retirement account. So if we set a default for a behavior that we want to achieve and it automatically happens, then we're more likely to perform that behavior. Salience suggests that our attention is drawn to what is novel and seems relevant to us. So we did nothing in that sense. Priming suggests that our acts are heavily influenced by subconscious cues. And then affect is playing to the appeal or affect or the emotion of a particular change agent. And then making a commitment suggests that if we make a social commitment, if I say to you up here, I'm going to, in 2019, I'm going to contribute $1,500 to the Salvation Army. I'm socially accountable to all of you to contribute $1,500 to the Salvation Army in 2019. And we paid no attention to making social commitments that might influence someone's behavior. And last is appealing to someone's ego. If we make someone feel good through the behavior, the intended behavior, then they're more likely to do that. So you can see that we paid very little attention to these practices or influences on human behavior. All right, so I apologize for the scheme, but I'm going back to a flow here that was more relevant to the EAB presentation. But what I intended to show here is just the figure at the bottom right of the screen, which is a behavioral psychology and the influence of now behavioral psychology and health informatics and user-centered design into a second generation of prescribing. So we're deprescribing in better senses and using these elements of behavioral psychology at both the individual level and the system level. So I'm going to share with you a brief story about a 63-year-old who we had an opportunity to deprescribe in an individual sense. So this is a case of Mrs. S.J. She's 63. She has a very complex medical and surgical history. When she showed up to the Aging Brain Clinic at Eskenazi, she had experienced a 2-year decline in both cognitive and physical function. She was on 28 medicines. She was on 6 medicines with adverse cognitive effects, 4 of those being anticholinergics and 2 benzodiazepines. So when I showed you in the first couple slides the anticholinergic cognitive burden scale, and if we sum the score of medicines in those scales, we think a score of 3, above 3 is bad. She was at 15. Okay, so her baseline cognitive testing, as I said, she's on 28 medicines, ACB score of 15. And our dashboard here suggests that many of these features of her care, maybe not her care, but many of the features of the medicine she was using and her cognitive performance were poor. Her MMSE was 16. She could not complete the summary. She could not complete neuropsych cognitive testing at baseline. She was minimally depressed, but she had a long history of depression. And her self-report, she couldn't finish the self-reported HABC monitor, which assesses biopsychosocial function of the dementia population. After 12 months of working with her to clean out some of her medications, we were able to reduce her medicines from 28 to 20. We got her ACB score from 15 to 3. We reduced the number of strong anticholinergics that she was consistently using from 4 to 0. We were able to make some reduction in the dose of her benzodiazepines eventually towards the end of that 12 months, but we could not stop her from taking benzodiazepines in that time frame. As a result, her MMSE increased from 16 to 29. Normal score is 30. You and I, all of us in this room should be at 30, maybe 29. Maybe by the end of me talking 29. But she showed a significant response in her cognition, or at least her testing. Her summary neuropsych testing was then within normal limits for an age and sex matched control. So there's a significant improvement in there. And although minimal change in her depression, but from a reporting perspective, it shows improvement. She gave us a really nice response, a really nice opportunity. Now that, as I mentioned, it took 12 months to accomplish this. So we learned from this that there's a significant back and forth in deprescribing. It takes a fair amount of time. It takes patience. It takes buy-in. We primed her. We used a number of these behavioral nudges to improve her medication profile and hopefully her outlook. So we're trying to take these lessons and apply them also to the system over at Eskenazi through the Brain Safety Learning Laboratory funded by the AHRQ. Oh, that's a wrong title. Let me skip to the next one. So if we talk about deprescribing in a system, you may have heard Dr. Callahan or maybe Rich Holden talk about the Brain Safety Learning Laboratory, Dan Clark as well. But in the Brain Safety Learning Laboratory over the course of the last 3 years, we've done a deeper dive into understanding why our patients and providers either prescribing or continuing to use anticholinergic medications, despite the fact that we've known for almost a decade that these medicines are bad for brain health. So we tried to understand through the Brain Safety Learning Laboratory all the stakeholders that are relevant to anticholinergic medication use, and we found a number of opportunities for intervention. We also learned from our prior experience in deprescribing when we utilized primarily physician-focused or provider-focused interventions that did not work, that perhaps we need to expand our scope of influence in deprescribing, and not just focus on deprescribing interventions focused on the physician, but also raise awareness and introduce opportunities to influence patients' decision-making with respect to anticholinergic medication use. So the aim of this particular study is to reduce exposure of potentially inappropriate anticholinergic medications among older adults receiving care at Eskenazi Health. And so we've developed, through support from this grant, we've developed some tools to aid the enhancement of awareness from the patient and caregiver perspective. So we created a set of 3 videos that tell a story of how patients might not be aware of the risks of anticholinergic medications and the availability of alternatives. I'm not going to show you those videos in the interest of time, but we've got some videos that were intentionally designed to tell a story of people like patients of the Eskenazi organization who are using medicines for seemingly benign reasons like allergies, like sleep, and the risks that they may pose. And they see a character, the patient or caregiver would see a character just like them, who is educated about the risks and makes a decision, is told about alternative approaches to managing those symptoms, and makes a decision to improve their care by changing medications or stopping those medicines. So we've got 2 sources. One is through those videos, and the other is through an app that we've created with design support on the inside and external programming support. And the app does very similar things. There are 3 core features. One is to raise awareness and provide education of the adverse cognitive effect of medications. And 2 is to help patients identify what those medications are. And then the 3rd is to provide a personalized risk score. So a user can punch in their age, their gender, and a few other demographic characteristics about their own history and their medical history. And what you see in the figure on the right is a personalized risk score that pops up as a dial and tells them whether their brain is, because of their medicines contributing to a green, yellow, or red, safe, of concern, or high risk for future cognitive decline. And then we're now enhancing that feature with some resources of, don't go kill yourself if you hear this information. Here are some resources, how to talk to your doctor. This isn't urgent. You don't have to do anything today, but you kind of do have to do something today. And the thing you have to do today is have a conversation with your provider or your pharmacist about how you can change your risk. And so these are the resources that we've created through the support of the Brain Safety Learning Laboratory. And we're also keeping the EPIC component, the computerized decision support component, because we feel like it's necessary but not sufficient alone to have an influence on the second generation of deprescribing in the future. So we have been working with EPIC programmers to introduce some best practice alerts intended to target the primary care population, primary care providers of Eskenazi. And in doing so, these best practice alerts, along with the patient awareness, we're going to couple the best practice alerts along with the patient awareness interventions to try to prime patients and physicians right before they have an outpatient visit together. So the patient experiences or interacts with either the videos or the app right before they're in the room, right before they interact with the physician. And the physician is going to be primed with a message about this patient using a medicine that has an adverse cognitive effect. And through that priming sense, we hope that will at least prompt a discussion. Now, Rich Holden in our Brain Safety Learning Laboratory has done some preliminary work about whether the app itself would cause people to initiate a conversation with their physician. And as much as we can, we have a small sample size, but we were successful in finding that 90% of people who interacted with the app reported that they would have a conversation with their physician in their subsequent physician interaction. So we think that that's promising, and that has provided some preliminary evidence for another R01 that Malaz had mentioned that will start later this summer, hopefully, if funding comes through. Again, a very fundable score, but the purpose of that is to test whether the app is successful as a method for deprescribing. So the second generation of deprescribing, we're paying better attention to the messenger. We're paying better attention to setting norms, providing defaults. Now, in a sense, we do provide some results through the best practice alerts. I put that in parentheses because the best practice alerts make it very easy. Once a provider decides, or once a provider indicates that they are going to make a change in medicine, that making that change from an ordering perspective becomes very easy. But we fail a little bit, and we don't set an automatic default that everybody using one of these medicines is going to default to a taper off. And so that's a bit of the paying attention a bit to the climate and what we have control over versus what we can support. But we are making it very easy that once a provider makes a decision, there's a taper schedule for all the medicines that we're particularly concerned about. We're paying attention to priming through providing messages to the physician and the patient right before a visit, and we're appealing to affect in the best practice alert makes a statement that the healthcare organization, the healthcare system, is endorsing this patient safety goal and making it a system-wide motivation. And Dr. Callahan has been having discussions with Eskenazi leadership at all levels, from the perspective of primary care leadership and even facility leadership, to endorse this approach. So as Malaz mentioned, I skipped over it because it didn't flow very well with the makeup of the slides, but I also have an R01 that's not necessarily system in scope, but patient in scope. And this is a cluster randomized trial that introduces a pharmacist intervention to support deprescribing of of primary care older adults who are using anticholinergic medications. And we're going to zoom in here in this particular trial and understand what the best approaches for deprescribing these medications are at an individual level through a collaborative pharmacist intervention. We're also going to understand what the clinical outcomes are, the primary outcome being cognition. And we're testing the hypothesis of whether brains actually are going to get better if we take people off of these medicines. And not just acutely better in the course of a matter of weeks or a couple months, but better in the duration of up to 24 months or 2 years. And that will tell us if truly this is a potential dementia prevention. We are going to use process measures as well as medication use using that rich data source from Regenstrief as well. So my last couple slides were to summarize these two system-based and individual-based, system-based and patient-based deprescribing work that we're engaging in primarily with Eskenazi, but also IU Health. And then I want to go back, I'll close by going back to my invited feedback in recognizing that Regenstrief itself is an entity that has expertise in computerized alerts in informatics, in health informatics. I would invite your input on best practices for physician-focused computerized alerts. We've tailored some of these, but we're also stuck a little bit in working within the best practice design that Epic allows for Eskenazi. And given the time frame that we've had to put these together, we've had to kind of fit within some of those constraints. But to the best of our ability, and it wasn't complete, but to the best of our ability, we're trying to use the behavioral psychology nudges when we design those. I'd also invite your suggestions on how best to engage patient and caregivers in printed mobile applications or web-based, video-based educational materials. And then lastly, if either now or as a follow-up to this conversation, I'd invite some suggestions. Let's suppose the second generation of deprescribing fails. What are our next steps for changing the use of, the frequency or use of potentially inappropriate medications in this population? Do we learn best from the opioid crisis, where we have to target payers to ask them not to pay for these medicines, or we target the FDA to take these medicines off the market? Those are significant events, but that may be where we need to go. So I'm going to stop there. Thank you for your attention, and invite any questions for clarification or suggestions for this work.
So, Noll, I was wondering how much you and your team have talked about money and cost and the context of formularies and tiering and things like that happen. So to pick on an example from your slide, you had oxybutynin and then an alternative drug. The average retail price of oxybutynin is $40. The other drug is $400 plus.
Yep.
So over a year, you're talking about $500 versus $5,000. And even for somebody like me, knowing something about the evidence base, that's an extra $4,500 for how much risk and how many other drugs I might be thinking about. And so I think a lot of pharmacies and PBMs, the pharmacy benefit managers, use these sorts of tools and are already fairly effective in changing what actually ends up in the patient's home because of using financial levers.
Great question. So it does present a challenge. And quickly I'll address that, is that we, at this point, have been unable to address that barrier. We see that as somewhat of an external barrier that we've not been able to address. Yes, the argument from a payer's perspective in looking at a month-to-month or 12-month time frame, that does seem like an activity that payers are not going to be excited about. And we've heard that from pharmacies. Retail pharmacies hate deprescribing in general, and I understand why. But the business of deprescribing in the short-term sense is a potential barrier. But if we think about, yes, it could be a few cases of dementia that we could prevent if successful. But if you think about the cost, the long-term cost of dementia, that's our only leverage. We haven't gone there yet, but I think that is a barrier that we realistically run into in the immediate short-term cost of drug for that particular indication. Now, there are other drugs that are anticholinergic that have neutral costs or maybe cost advantageous. So we did do a cost analysis using Eskenazi data And outside of the oxybutynin case, most of the deprescribing alternatives are cost neutral or potentially cost advantageous, given the risk.